So molecular testing keeps getting better and better. We are working on ways to improve the turnaround time of the testing, and these approaches are both technical and systems for how to get data quicker to the patient. We have advances where we can do molecular testing on blood for many patients. We talked a bit about tumor mutation burden. This is a new way of using that same information to help predict immunotherapy efficacy. In terms of the integration of PD-L1 with molecular testing, it's notable that some of the providers of this kinds of testing will bundle those for you, where they'll give you molecular testing and an IHC for PD-L1 together. I think this is a smart practice that's very doctor-friendly, very patient-friendly. And I guess the final thing I would say is that there are new testing modalities that using molecular testing and bioinformatics that may answer different questions. And what I would particularly highlight are expression signatures. These are mRNA expression patterns that can predict drug efficacy. For example, Genentech's T effector signature, or some of the interferon gamma signatures that we've seen publications on.
In non-small cell lung cancer testing, I think in the future we're going to see more and more smaller panels which are able to detect relevant single nucleotide variants and small insertion deletions in EGFR and KRAS and other genes, but also panels that are able to detect relevant rearrangements such as ALK, ROS, and emerging targets like RET and NTRK1 and NTRK3. We're also seeing more and more incorporation of tumor mutation burden and PD-L1 status. So now it's really routine for any advanced non-small cell lung cancer case with an adenocarcinoma component that will have NGS testing performed for the relevant alterations, and likely tumor mutation burden testing as well as PD-L1. And really, I think what we're starting to see is it's becoming more and more routine for non-small cell lung cancer that clinicians are ordering so-called liquid biopsy, and so we can detect a lot of these alterations, well not necessarily PD-L1, but other alterations that are potential drivers in non-small cell lung cancer through these assays, as well as potential resistant mechanisms to drugs that are being used.
As we move forward in understanding the molecular biology of non-small cell lung cancer, we're certainly going to use mutational testing more. I think what I thought a few years ago is that we would continue to identify small subsets of patients, that 1 or 2% population, and continue to build out a pie chart that showed which drivers were important. I think that's going to continue, but I think that's probably a little bit less important and probably a bit more long-term from what we're also going to see, which is a focus on the concurrent molecular events in patients who have driver oncogenes or without driver oncogenes. I think we can learn a lot from those concurrent molecular events. Probably the big overview of those is tumor mutation burden. So if there are many concurrent molecular events, that gives a high tumor mutation burden and leads us to identify patients who should get immunotherapy. But for instance, we've seen recent data that suggests that patients who have EGFR mutations, but also have P53, seem to benefit a little bit less from EGFR mutant therapy. And so we're going to learn more about that. We're going to identify patients who could benefit from more intensified approaches to their therapy. And I think all of this together really builds off the foundation of important molecular testing that can be done for all of our patients.